I start this both with a title that I can't explain and maybe you can't either. But at the end of this, hopefully we can have a discussion and come to some shared understanding of what it is. But I point out Dr. Zafran was one of the early participants in a current research study that we're doing right now. And she was a cultural linguist. And as she would say, words matter, and what you say matters. So from Dr. Zafran to this presentation, that is really what the title is that words matter, and I'm hoping to understand this in a way in relation to how we communicate about prognosis. On the left side, it's not showing up here very well, but imagine a picture right over here of a punt, which I'm learning what they look like. In the promotional, in the newsletter here, I said that I'm coming back in January to do a visiting fellowship at the University of Cambridge, doing some really important things and punting on the Thames. And it didn't really go over very well. So I think I'm going to be spending my sabbatical carrying my punt from Oxford to Cambridge for about 6 months. So if you see me along the way, please give me a lift, because that's where I'm going to be probably. So next 45 minutes, I would like to both describe our approach to a conceptual model, into measurement, into some analyses of what it means to have and engage in a prognosis conversation in palliative care settings, at least the settings that we are studying, to share some of our findings that we have already published and some that are preliminary. And then for the remainder of the time, I would really like to hear your ideas about the evolving concepts that we have. And what are we missing? What are we overemphasizing? And what could we do to improve this? I'm going to talk about some things as if there's only one definition. And I think that would be unfair, because there are many definitions, or at least concepts, to the things that I am trying to study and present here. So let me describe what I mean about two of them. One is the word prognosis. When I use the word prognosis, I'm going to be referring to a prediction about a future course of an illness. And that might be about life expectancy. It may be about symptom burden, functional trajectory, and it may be something that we may refer to as anticipatory guidance, is helping people understand what to expect. The other concept that I will be using in some of this presentation is the concept of patient-centered, or patient-centered care, or patient-centered outcomes. What I mean by this is that clinical processes that promote people feeling heard and understood and valued, and that help achieve value concordant or preference concordant treatments. We're living longer, and for those of you who really don't, I guess the good news, if life expectancy is not something that is easy to talk about or something that you're particularly interested in, you won't have to worry about it very long. So pretty soon we'll be living forever, and that will be off the table. Until then, we really need to understand how to talk about this. So although we're living longer, and we're not living more simply. Does anyone have a sense of what this might be here? So these are Crayola crayons. When I was 4 and I reached for my crayons in 1902, I had 8 choices, right? And that was what my brain had to deal with. Right now, you reach for crayons and you're 4, you got 256 choices. And in fact, more than is even on this slide. Point being that the decisions, the choices we have to make, that we have the luxury of making, but also the obligation of making, are intense. And you all know this in the context of serious illness. And that's the context that we're dealing with as well in palliative care. Consistent findings in the emerging science of palliative care thus far is that palliative care consultation helps, particularly in serious illness, to achieve what might be considered patient-centered outcomes. But the active ingredients, or what really is happening in palliative care consultation, remain relatively speculative in our science. There are some early findings that suggest that communication about prognosis, in the concept in which I'm presenting it, may be one likely element of palliative care consultation. In particular, because we know from plenty of observation that the concepts of prognosis, both in life expectancy and what to expect in terms of functional course, are oftentimes avoided or flavored so optimistically that it may not be recognizable in a lot of medical care, at least in the United States. That palliative care interventions change, they influence perceptions of prognosis, and that perceptions of prognosis are associated with outcomes that patients and families will define as being patient-centered. The research setting that I'm going to present some of our findings today, it is from palliative care consultations in hospitalized patients with life-limiting illness, Usually the inclusion criteria for what we're going to present are that the clinicians would not be surprised if the person died within 1 year or within 6 months, depending on which study I'm referring to. And that these observations come from a large medical center in the Northeast US. Now there's some things that may be a little bit different. You know, I'm studying this in the United States, which is a pretty high utilization area. A lot of what you're going to hear may be very similar, but some might differ based on the patterns of utilization that we see in the States. So the beautiful conceptual model that is showing up right now, this all begins in some concept of what we're trying to measure, what we're trying to study. And so in developing a conceptual model, really developed this with two primary things we wanted to communicate. One is that a conversation, in the way we're conceiving of it, is a dynamic and relational thing. This is not a sender-receiver exercise, but rather one in which participants engage in creation of a conversation. And two is that it happens in context. What that context is and what constitutes context is where our work lies. But what we wanted to start with was being able to convey that this is relational, it happens in context, and it involves participants who come to the table with their own beliefs and perspectives and motivations. And so we've begun to measure some of these things, and I'll describe a few of each of these domains. In the blue area is the observable part of a conversation, because our work, we're directly observing palliative care conversations, we're audio recording them, and we are training our research assistants, most of whom have been nurses, to observe and record oftentimes the nonverbals and other things happening in the room that we don't particularly pick up on audio recording. But so the engaging in conversation, this is defined. Some of the pieces of this that may operationalize this concept are: who brings up the issue of prognosis? How does it come up? Is it a question? Is it a spontaneous comment? Is it brought up by patients, families, clinicians? Does it come up early in the conversation? Does it come up later? Does it come up in the context of discussing preferences? How might we agree that we're going to talk about this? What are some of the rules that we're going to try to set out for the conversation we're having? Or do we jump right in and figure it out as we go? How often is this a turn-taking exercise, or is this more of a monologue? You know, who has the floor, and how often are we giving each other turns to speak? And so in exchanging information, this can refer to the quantity of information, how many times. Oftentimes what we'll do for quantities, we will divide conversations into segments. Each speaker turn is a segment. And so in quantity, it may be how many segments of those conversations are people discussing the topic of prognosis. And in those segments, what is the topic? Are we talking about life expectancy, symptoms, functional trajectory, or other that might fall under the umbrella of prognosis? And when we talk about it, are we talking about it in a conditional way? If we choose treatment A, B, or C, then we might expect this to happen. Or are we talking about it in an absolute way? This is what I expect to happen, regardless of the treatments that we're choosing. And affect. How often is this information cued with affective language? Unfortunately, the good news is those trigger what we might consider hot cognitions instead of cold cognitions. Having said it that way, I think that most of these conversations are pretty much, our hot cognitions are operant almost the whole time as well. But in the language we use, we can see the affective labeling. So in addressing emotion, what type of emotions do we see? In particular, we're, for the concepts of this conceptual model, we're identifying the affective cues that relate to prognosis, either that come at the heels of discussing prognosis or that identifiably speak to, oh my gosh, I wasn't expecting this, or this is so scary. And so the type of cue that we see, the intensity of that cue, is it a passing comment, or is this really something where people are having a hard time holding it together as we're talking about this? And the response to these cues is the clinician or the family member, the other participants in this conversation, are they changing the topic? Are they engaging this in a compassionate response? Are they ignoring it in any other ways? These are the types of responses that we'll be looking at the affective cues that come out of a conversation. And when it comes to balancing, we started this with framing uncertainty early on in the conceptual model building, and we changed the word framing to balancing, if for no other reason that framing has had a lot of different meanings that get attached to that term. So we used the word balancing. And this refers to the fact that we are talking about something that is uncertain, which is the future. It may be more or less uncertain or perceived as such to different participants in the conversation, but there's always room for different frames and cues that are placed on the information you're having. Now, by default, we're using the terms optimistic and pessimistic because every time we try to use a different term, it doesn't seem to work. What I am referring to here as affective cues may be referred to as sunny or cloudy. It's not necessarily optimism and pessimism as a departure from truth, but rather how is the flavor of this message? Is this a good news message? Is this not a good news message? That tends to be more of the affective, primarily linguistic cues that we see. And focus, this is something we saw early on and that we've begun to characterize a little bit. The focus of these prognostic statements, in particular, kind of the deductive distance. Am I saying that 30% of people with a cancer such as yours might experience this, which might be deductive at the population level, which may have a couple inferential steps to get to me, versus, Bob, there's a 30% Bob that 30% chance, Bob, that you're going to have this outcome. That's more tailored to the individual and is one step a little bit closer in the deductive scheme of information sharing. So that's another type of uncertainty balancing that we've been focused on. So a couple of the things, just to show you how we would measure this and what we tend to see in the palliative care conversations that we're witnessing, is one is that the topic of prognosis comes up in it was 92 or 93% of the conversations that we've measured, which are now up to 150. And the topic, at least from a segment count, for just the frequency of how commonly this is discussed, is more about quality of life than quantity of life, but quantity of life is present in over 2/3 of the conversations as well. The focus is almost always about the individual, and less with the population-based comments that I made before. Although they're present, they're much more about, Bob, I think this is what we're expecting to see here, which we might call more of a tailored individual focus. The cues, the vast majority of these prognosis segments of the conversation about prognosis isn't heavily cued with affect in these conversations, at least identifiably. But when it is, there are more pessimistic than optimistic messages, at least on balance, which is relatively new compared to what we observe in other direct observation research of pretty heavily optimistic cued. So the emotions that are present in these conversations, they're identifiably, now these are reporting emotion based on what we can hear on audio tape. So all the emotion that is present in the nonverbals and the relating to one another, we're not capturing here. But about 70–75% of these conversations had identifiable linguistic cues of emotion, fear and anxiety being the most common, sadness, and followed by anger. Now, the responses that we've been seeing in these conversations, overwhelmingly what we've seen is a compassionate response that addresses the emotion that just expressed itself in the conversation, very infrequently ignored or diverted to medical information as a response. So here is this is a picture of an eagle. What we've begun to do with our conceptual model is we've begun to measure these multidimensional phenomena. So we can measure in our imagined eagle here, we can measure the beak length, the wingspan, the talons. We can measure aspects of this bird. And we might, from an epidemiologic point of view, we might find that conversations that have longer talons achieve more patient-centered care. But this next picture is a penguin. So if we take those talons, if we conclude that talons are good, we're not going to be able to apply them on every conversation. It's not going to help in some contexts. So what we're moving towards is that we're moving much more, our team, towards an ecological understanding of conversations. And that is that conversations have multiple complex dimensions. They organize in patterns in ways that may have identifiable subtypes of clinical conversations. And depending upon the habitat in which those conversations and those features exist, they may be more advantageous or they may be more disadvantageous. And that is where our work is taking us now. The first steps here are beginning to define, well, what do we see as types? And in our early work here, we've found that in our conversations, there are three particular patterns that emerged of types of conversations, or subclasses. Now, for those of you who do latent class analysis, you'll understand the methods we used for this. But it's quite similar to, at least in concept, to exploratory factor analysis when you're dealing with many different measurement domains and you're trying to establish patterns among them that might identify either latent constructs or latent ideas, in this case, latent classes of a conversation. So here is our latent classes. Each one of those fingerprints, so to speak. Now, any geneticists in the room? There's no geneticists. Whenever I show these lines, the geneticists, they start to wake up. They say, wow, I recognize that. That is my gel. What we see here, each one of those different color lines is a different characteristic of a conversation. And what should jump out at you, hopefully, is that these have different patterns. They look like different things. And so maybe I'll walk through this. So the first one, that top one, I've turned the many colors into one. But what we'll see in a little over half of the conversations we might call latent class A. And I'm going to have them, let's see here. So what this reads, and I'm not going to step too far away, is this is in the proportion of conversations in latent class A that have this feature. And for example, this latent class is characterized by a little less than a third of the time is initiated by patients or families. That it happens about half the time early within the first 5 minutes of conversation or later in a conversation, so it's about half and half. The discussion tends towards the longer side, which in this case we're defining as greater than 6 speaker turns about prognosis, which is about the median split for what we've observed in our conversations. That conversations about a small amount of them are uniquely about quality of life, that most of them have some information about life expectancy, that almost all of them have conditional prognoses. This is what the future is going to look, we expect will look like given this type of treatment. That emotions are oftentimes expressed up to about 30% of them. And then the cueing, the optimistic and the pessimistic cueing, we'll see a lot in these. Now, we describe these based on the quantitative criteria that came into measuring about 40 different dimensions, and we distilled it down to the 8 that seemed to provide the most clarity in our latent classes. And then we analyzed them qualitatively. My friend and colleague Sally Norton took the lead on beginning to qualitatively analyze the buckets of classes that our exploratory analysis found. What we observed qualitatively is that these Class A conversations, they typically are the goals of care conversations. They're the ones where we really are, we're wading through available treatment options, discussing prognoses and conditional prognoses, both about attempts to extend life and to attend to comfort. And so these are oftentimes the bulk of what we're consulted for and oftentimes what we see. And we were calling this a navigating options type of conversation. So the second two are about a quarter each in frequency or in prevalence of our conversations. And this one is characterized almost very rarely started by the patient and is characterized oftentimes by uniquely quality of life information, prognosis about quality of life. Conditional, about half the time, very relatively less emotion, relatively less cueing of the uncertainty that they're facing from an affect point of view. This type of conversation, what we typically see is that very early in the conversations, people are expressing their interest in better quality of life. That the heavy decision making in some ways just hasn't been communicated. It's, I don't want any of this, I would like you to focus here, will you listen to me, is oftentimes where these things start. And so these conversations, when they're conditional, the conditional prognosis is much more about how we're going to handle this feature that is a threat to their being, that is causing them suffering. And so that is where the conditionality shows up, but it's almost exclusively in how are we going to achieve better comfort and less suffering. That's usually where these conversations go to very quickly. So the third class of conversations that we see is oftentimes started by patients and families relatively late in the conversation, late being greater than 5 minutes, so it doesn't mean we're waiting till an hour and a half into a conversation, but are characterized by a relatively more emotion and pessimistic cueing of the information. And I'm wondering if this triggers, based on what you saw of the last descriptions of conversations, if this one, anyone thinks of one. Oh, go ahead. Oh, go ahead.
Asking how long do I have for those kind of discussions?
Yeah, so it may be people that are in some ways having a sense that this isn't going very well and wanting to give some voice to this, to some of the concerns, and that's exactly right. Is that this is oftentimes a time of preparing. I'm recognizing that things aren't going well. This is scary. How are we going to deal with this? So these conversations are oftentimes relatively low in decision making and high in processing of what is happening and what we expect to be happening in a relatively absolute way in the near term. Great, thank you for contributing. So with those, with our conceptual model, with identifying some latent classes or latent types of conversations, what we're moving to now and what our current research is trying to understand is what are the contexts in which these conversations happen. And we mean context quite broadly because this requires extensive exploration, in my opinion, including what are the cultural and group identities that people have when they come to the table for a conversation like this. What are the clinical scenarios that are playing out that help set the scene for a conversation? What are the structural environmental factors that are participating in conversation? So context, we need a better understanding of how those are playing in the creation of this conversation and how it works. And then function, so how well or not well, or poorly may I say, do these conversations achieve patient-centered care? And so what we're doing right now is what I've described to you so far has been relatively cross-sectional, has been observing conversations, describing them, contextualizing them. What we're doing now is an observational cohort of about 300 patients with advanced cancers who are hospitalized and who have been referred for palliative care consultation. We're doing this at multiple sites in the Northeast right now and soon in San Francisco. We're observing and audio recording the first 3 visits with the palliative care team, at least as this unfolds, usually over 3 days or so is what we're going for. And we're interviewing patients and families before and after. The after is after the first visit. Now these are brief interviews, and the measures we're using are designed specifically to be of low burden and to be stable among an ill population. We're hoping to achieve a sampling and a focus of the study that allows all to participate, not just those who have time for an hour interview. And then we're following people up for 2 and 1 month and 6 month follow-up, particularly for utilization, a little quality of life outcomes. And these are primarily telephoned, and they're very brief, 2 to 4 questions, and along with medical record access. And what we've been finding, and this is we have an extraordinary team of clinicians and research staff that have found a way to do this. In order to do this work in the busy, chaotic clinical setting, we need to have a small footprint. We have to do this in a sustainable way. And we have found a way to do that. And it's really been a joy to work with this group of people who can integrate this type of research in a setting such as this in a way that doesn't get in the way. And that feels value added to most of the participants who are in the study. So I mentioned that we're trying to understand context, and that requires what can be in some ways the greatest challenge, and that is to describe what a good outcome is. If I'm trying to study whether something functions or doesn't function, I need to have some way of categorizing that. And so we're operationalizing patient-centeredness to be care processes that achieve at least 3 aspects of these dimensions. The first is that patients and families feel heard and understood by the medical teams in particular. That quality of life and the multi-dimensions of quality of life are improved, or at least not the rate of decrease is at least slowed. And that the treatments that people receive are value or preference concordant, particularly treatments nearing the end of their life. One of the things we're finding very early here is something that I have avoided because it's made me a little uncomfortable. And so this is I'm throwing my hat over the wall here with this presentation, that I'm jumping into my, outside of my comfort zone. So please forgive me if I'm looking that way. When we start to look at the conversation where people feel heard and understood, I was expecting to see something that I wasn't seeing. You know, we're measuring aspects of conversations that are, in some ways, they're important, and don't get me wrong the way I say this, but they're relatively easy to measure. They're words that mean what they say. And so I can measure if prognosis was communicated because they said this word followed by that word. But as a physician, I mean, the beauty and the joy about what we do is in that relation, is in the nuance, is in the meat and the stuff of these conversations, which can sometimes defy explicit measurement of language. And so what my fear here is that I don't want to intend to be a mind reader. So when I'm trying to measure conversations, or my team is trying to measure them, when we try to say, well, what did they really mean by that, we pull ourselves back because we get into a range that we are going to all see something different. But what we can do, and my brilliant brother, who's a cultural linguist, has directed me to some work by philosophers of language. As with most of the ideas I think I have, I found out that a lot of other people had them for a real long time and have done a lot of writing about them. But in philosophy of language, Paul Grice describes implicature, and it is under the assumptions that a conversation in which people engage has some cooperative principles. We're doing something here that in general we are trying to engage in this phenomena that might have some norms to it that would constitute cooperation. And Grice describes them in 4 different maxims or norms. And it may be that the way he describes them are there's quantity and quality. You're not saying more or less than is needed. That you're being relevant in your speech and your communication with others. And that you're not trying to, the manner in which you're trying to do is relatively organized and not trying to obfuscate meaning. Now, of course, anyone who's been in a conversation ever knows that very few conversations adhere to these things in a very reliable way. And in some ways, that would be quite boring if they did. But what this provides is a set of norms that we can then describe with relative degree of inter-rater reliability if those norms seem to be what Grice calls flouted, meaning as someone seeming to not follow these patterns that we're describing as normative. And he describes them as conversational implicature. And he created this new word because any other word that was close to it had too many other meanings already attached. And so the idea here is that there are some norms to a conversation that when we are not following them, that we can see it. We may not know what the meaning is, but we can see it, that quantity is not being adhered to here. And it's not because people are trying to deceive each other or because they're disagree with each other. It is because these are rhetorical ways of engaging other people in a relational experience. In some ways it maintains dignity, defensibility, appropriateness of what we're about to talk about. And as I'd mentioned, and I think as I'd mentioned, these conversations happen in a very, very intense emotional context, oftentimes with very active suffering. And asking people to always be explicit with their language is neither something that people will do or may not be healthy all the time for them. And so conversational implicature is one way of beginning to look at nuanced conversation. And so maybe, I don't have this in front of me here, so maybe what I can do is just give you one example. For anyone who's either heard of or been part of conversations in palliative care, this may not look very foreign. It's a version of a hope for the best, prepare for the worst conversation, or at least attempted to kind of walk through some of those things. The underlying areas, the first one here, I didn't choose this because it's the easiest example of implicature, but because it's one we see and experience a lot. If you'll just look at the language used here, the first yups, they're close to a yes. That's an acknowledgement and endorsement of the preceding sentence. And then we got an that shows up. Now that depending on how we're using it, it is already identifying that this, both in the manner and the quality of that response, well, we're not sure necessarily what that means, but it's a little deviation from what might be considered the maxims of ordered and complete and unobscured communication. And the second one here is asking for a little explanation in some ways about this potential dynamic that we're in, about wanting to have these 2 or 3 or potentially 4 competing demands. And the response is really flouting the maxim of quality and quantity, and in some ways manner of the answer that's given is that how I'm going to handle this is relatively off bounds to what I'm going to be explaining to you. And if that isn't enough, we'll make sure that we'll ask for the urinal and stop the rest of that line of conversation. The example I give is when it comes to implicature or nuanced speech. Why I think this is important for our discipline in communication to try to go to is that this is the stuff of real conversations. And if we are trying to be patient-centered in the processes of care that we provide, and in how we identify and measure that in a scientific way, we're going to have to come to grips with how do we handle nuanced communication. And can we do it in ways that is measurable, that is reliable, and is scientifically valid? At least a couple of things that come up, and when it comes to if we were to use such a paradigm as what Grice is suggesting is, I'd imagine that those norms of conversations are going to differ based on our cultural identities and where we come from. And so we may have to begin to understand what does it mean to engage in a normative conversation? What are the rules? And so we may begin to understand when we divert from them, or when our rules in some ways are potentially at odds with one another, or when they're in parallel with one another. And when we get there, to understand other patterns to how we communicate and relate to one another that identifiably predict outcomes that we can come to as defining as good or as bad or as neutral for that matter. With the hopes being that not only can we improve our training and our education and clinical interventions, but we'll begin to understand this process of communication that I think clinically and as human beings we feel when things are going well or not going well, or when they've been valuable. But I think there's more we can do in the science to begin to describe that. So in summary, I described the conceptual model, at least where it stands right now. This is an evolution, and I expect even after leaving today, we're going to change some things of that. Some of the multiple dimensions of a conversation that we have found to be measurable and that we've applied to understanding different latent classes or types of conversations that we're seeing in palliative care context. I'm suggesting that implied, nuanced, and indirect communication is both common and important, and in some ways the next steps for us as a science to deal with. And that our evolving understanding of this science should help us with standards and training and interventions to promote patient-centered care. That is the end game that we are all hoping to achieve. And so I want to thank our research team. I have the luxury of traveling to England to present this at the Cicely Saunders Institute, which is a joy being here. I wish my colleagues, who are phenomenal, could be here, and I wish I had time to name all of them. I don't. But they are here with their names, and I understand will be up for a while, so please do take a look and see who you recognize. And most importantly, to thank our patients and families and clinicians who make this work possible and meaningful, and to our generous and dedicated funders, American Cancer Society and the U.S. National Palliative Care Research Center. And to you guys, who are really the trailblazers in our discipline, whom we are following with both admiration and enjoyment. So thank you for what you do.